Andrea, can you hear me?
Yep, I hear you.
You're talking to both of us? Yeah.
I would like to make sure both of you can hear me.
Well,
I
that's
just want to
needed
make
then.
sure.
Yeah.
And now we can see everybody. Wonderful.
Morning.
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 Good morning. We're just giving people time to log in, I guess.
Claire, can you try talking again? Because last time you talked, it was breaking up.
Me?
Yeah.
Oh, sorry. Yeah. Can you hear me, Peter? Can you hear me, Peter? Okay.
Yes, but you're freezing a little bit. Hmm.
You're all live and moving around on my screen, so hopefully I'll be more animated.
And I'm told that a lot of the staff is going to be, reviewing, watching it afterwards or throughout the day because of meetings.
Fine. Will you let us know when we should get rolling? Someone from the Connecticut offices can let us know when they'd like to get started. But we can give people a few more minutes to log in. We're actually early. It's only 3 minutes of, so we got time. It's pretty cold in Virginia, so I can only imagine it's pretty cold in Connecticut.
It's kind of frigid here. Yeah.
Good morning, everyone.
Morning.
Morning.
Peter, great to see you. It's been a while. You look
Yes,
great.
thank you. Thanks, Claudia. Thanks for helping with this.
Peter, we could give it a few minutes. Maybe I'll just
Good
sort of
morning.
introduce sort of the cross-section of individuals that we have from the Connecticut team, and then can I turn it to you to sort of kick it off for our briefing?
That sounds great. And Claire Gill, who's the CEO of the
Okay,
Bone Health and Osteoporosis Foundation, will introduce folks on our end.
great. Thank you. Good to meet you, Claire.
I'm mic'd up. Nice to meet you too, Claudia. Thank you so much for arranging this.
So I see we have critical mass, and I know we probably will have questions and want to reserve some time, knowing that you all have about a 45-minute presentation for us, and we have an hour booked this morning. So I will start with brief introductions and give a sense of the audience that we've been able to collect for this briefing and this engaging conversation this morning. So I'm Claudio Gualtieri. I'm here at the Office of Policy and Management. I lead the Health and Human Services Division. The Office of Policy and Management is the governor's staff agency, so we coordinate cross-agency policy development, we lead governor's bills, and we help develop the governor's budget. And we're right in the process of that budget development. The governor's budget corrections are due to the legislature in February. It will be the kickoff of the short session in 2026. And on the call, we've sort of gathered representative expertise from the key agencies that may be thinking about ways that we can reflect what you're going to present into value-based investments to reduce costs but promote better health outcomes. It's related to osteoporosis and women's health and bone health. And so you'll have on today's call leadership representation from the Department of Public Health, thanks to Commissioner Giuttani and DPH Policy Director Melissa Morton for being here, the Commissioner of Aging and Disability Services, as well as the Commissioner of Office of Health Strategy, Commissioner Amy Porter, and her team. We have the lead of our Health Information Exchange, Connie, which is Sumit, is here. We have colleagues of mine from the Office of Policy and Management, including in our budget division and the Health and Policy team. We have also representation from our Medicaid agency, the Department of Social Services, and our long-term care ombudsman, who's a terrific partner on a lot of aging policy, Mairead Painter. And with that, Peter, I'll turn it over to you to let you know that we've also, I should also say, in addition to state agency representatives, my colleague Melissa Morton invited some of our external partners. So we have AARP represented in some of the stakeholders on the long-term care planning and advisory councils in the state. So with that, Peter and Claire, I'll turn it to you to do introductions and to jump right into the presentations.
Thanks, Claudio, and I'll turn right over to Claire just to keep it moving. Sounds like a great group. What a
Thank you. Yeah, no, thank you so much, Claudio. Thank you all for being here. We greatly appreciate it. And it sounds like it's an incredible group from the state of Connecticut. And just delighted to see you all working together to advance women's health and particularly bone health and menopause. So I will just kind of briefly introduce myself and my colleagues. I'll allow them to come around and introduce themselves very briefly, and then we'll jump into what you see here. We would like to cover some details on menopause and osteoporosis, and then the impact that bone health has on the state of Connecticut, what citizens can do, and then some policy solutions. So I am Claire Gill. I'm the CEO of the Bone Health and Osteoporosis Foundation. And my other hat is I founded the National Menopause Foundation. And our two organizations have a synergistic relationship because menopause is such an inflection point and for women and their bone health. And so I'm delighted to be able to represent both organizations today. And as I said, joining me are several of my colleagues. So I'm going to first allow Dr. Andrea Singer to introduce herself.
Good morning, everyone. Andrea Singer. I am at MedStar Georgetown University Hospital in Washington, D.C. I am a practicing clinician, internist by training, but sort of think of myself as I guess I could call myself a menopause and PCP bonehead, primary care bonehead. Do a lot of osteoporosis. I run our bone densitometry program. I run our secondary fracture prevention program. Do a lot of midlife women's health and all in teaching. And I'm also chief medical officer at BHOF.
And one of our fantastic advocates and experts from the state of Connecticut, Dr. Kate McLeod, is on the phone. Please
Hi,
introduce
thanks.
yourself a little bit.
Thank you. Catherine McLeod, Associate Professor of Medical Sciences at the Frank H. Netter, MD School of Medicine here at Quinnipiac. I also direct our scholarly reflection concentration capstone course for our medical students and also co-direct our health policy and advocacy concentration in the medical school. My research focuses on osteoporosis prevention and management with an emphasis on improving care gaps. So I'm happy to be here.
Thank you so much. And a person that you all should get to know because she will be doing all of the follow-up from this conversation is Andrea Medeiros. Andrea, please introduce yourself.
Hi, I'm Andrea Medeiros. I'm the Vice President of Public Health and Policy at the Bone Health and Osteoporosis Foundation.
Terrific. Thank you. So moving on. Well, here we are. So let's talk a little bit first about menopause, and then we'll dive into that impact on bone. But why it's so important that we prioritize midlife women's health is that approximately 1.3 million women enter menopause every year in the United States, and we're spending a longer part of our time on this earth postmenopausal because we're all living longer, which is terrific. Women are living longer, but we're not living healthier. And so addressing some of the chronic diseases that impact women at the onset of menopause is critically important for our patient population. In addition to symptoms that, again, are caused by the reduction of estrogen in a woman's body at the time of menopause, there's increased health risks. And so we need to do a better job of explaining to women how their risk for osteoporosis, for breast cancer, for heart disease, and for Alzheimer's and dementia are increased at midlife. And so we do a lot of work with the National Menopause Foundation to ensure that we're not only helping women to address the symptoms that they might be having or experiencing during this natural phase of life, but also helping to educate her and clinicians about the importance of preventing chronic diseases that, again, our risks are amplified for during this stage of life. So studies show that many symptoms associated with this change of life also directly impact women in the workplace. Approximately 4 out of 10 women experience some type of symptoms that they say interfere with their work performance and productivity. And 17%, although I've seen that number up to as high as 30%, actually quit their jobs because of the symptoms that they're experiencing at menopause. And this is just unnecessary, and we need to help women understand what's happening to their bodies and providing them with the access to care that they need so that they continue to thrive and we don't lose these senior level women in their careers to just not being able to manage the symptoms that they're experiencing at this stage of life. So there's 4 main areas we're working on to close that care gap. One is science. We do not know enough about female biology at this point. It has been grossly underfunded and understudied, and we need to make sure that we do more to address that. We need more data about the burdens women are experiencing. What we do know, we think is really very much underestimated because, quite frankly, women haven't talked about what they've experienced because of stigma associated with menopause and aging. Care delivery, women are likely to face a lot of barriers, and we hear that consistently at the National Menopause Foundation, in that they are dismissed for their symptoms, or they can't find someone who understands and is qualified to actually take care of them at this stage of life. There's no one that really owns this stage of life, which we'll hear a lot about, a lot of similarities to bone as well. Your OBGYN is really focused on obstetrics, and so very little training. I think there's 4 slides in all of medical school that address menopause. And so that's even for obstetricians and gynecologists. And so we have a lot of work to do in ensuring that women can access that care. And then investment. There's just a lower investment in women's health conditions overall. And again, when we are more than half the population, we need to address these issues because it's going to have a huge impact not only on our society, but on our health system and obviously on our economy. So we did a study with Bank of America a couple of years ago that looked at what women are experiencing in the workplace. And again, this matters when we're talking about the economy of our states and making sure that, again, businesses are thriving. Half of the women reported some type of negative impact in their work during this stage of life, while 76% of HR managers thought that they have a really great place for menopause to be freely discussed. Only employees said that there was only about 3% who talked about HR about this. 71% of employers, again, had a positive thoughts about what their corporate culture was, and only 32% of women felt the same. So the number one reason, interestingly, that employers said that they don't cover menopause benefits is because women didn't ask for it. And again, when you have the stigma around midlife and aging, women have not asked for it. It does not mean they don't need it or don't want it. Fortunately, states have been very active in this, and we're seeing a lot more activity at the state level, and we're very grateful to all of you for taking an interest in this and for the work many of you have already done in this area. But I just wanted to give a quick summary, and this is from the end of August, so some of this may have changed, but several bills have been introduced that talk about insurance coverage mandates, and so these are a few of them that require that. Several, including Connecticut, have brought forward legislation talking about provider education and training. Again, addressing that care gap I mentioned, where clinicians don't learn about menopause or women's midlife in medical school. So how do we ensure that we are getting clinicians to be fully up to date on what they need to know to treat their patients? Public awareness and education campaigns were addressed by several other state legislation, and workplace protections have also been addressed. Rhode Island, as you may have heard, has been the first and only one that has passed workplace protections for women at menopause, and we hope to see many more of those in the future. So again, as of August, the end of August, 5 bills were acted, 11 remained in committee, 7 passed with some type of capacity, and then several were vetoed or denied, and 1 was amended. So progress, but given that we have 50 states, we have a lot of work to do in this area. So now I'm going to turn it over to Dr. Singer to go through osteoporosis basics.
Thanks, Claire. Feel free to sort of stop. I know we'll have time for questions at the end. Some of this may be review, but I think it's important to at least level set with a definition of what osteoporosis is, which is pretty evident from the pictures. They say picture is worth 1,000 words. And you can see the difference between normal bone on the top and osteoporotic bone on the bottom, which characterizes this systemic disease that is, by name, porous bone, characterized by weakened and fragile bone tissue which leads to an increased risk of fracture. Fractures are the ultimate event or sequelae that we're trying to prevent. That's why we care so much. We'll talk about that more in a moment. But it's a silent disease until a fracture occurs. Most women don't know, and this doesn't only affect women, but we'll talk mainly about women today, that this is occurring. And because of that, it remains underdiagnosed and undertreated, and the consequences are major. It's also a chronic disease that we can treat effectively, but we don't cure. So it requires long-term attention or management. Next slide. I think many people think that bone is just something that's there, right? It's this inert substance that kind of supports our body, lets us walk around, and protects our internal organs. But it's actually really a living tissue that is constantly remodeled, and the entire skeleton regenerates itself every 10 years, which I think is a really interesting fact. The remodeling process, which is quite complex, and this just gives you an overview, is the process by which the skeleton is maintained and renewed. So we're able to repair little microfractures, microdamage that are part of or the result of what we do every day in terms of walking around and weight bearing. And in a normal state, these processes of bone breakdown and remodeling and new bone deposition and formation are matched, and that's how bone keeps its strength. That can change, though, certainly in women after menopause. That loss of estrogen, which is protective, is often sort of the defining event for the development of osteoporosis. And this can lead to compromised bone. This can occur because of other reasons, other diseases as well. But part of aging and following menopause, that is probably the single most important cause. Next slide. So this takes a look at what happens across the lifespan. When your kids tell you that after the age of 30 you're over the hill, from a bone health perspective, they may not be so far off, although I'd like to argue with them about it in terms of other perspectives. This speaks to a couple of things, one of which we won't really talk too much about today in terms of concentrating on this age range. But for those of us who have kids or know people with kids or have grandkids, what we do when kids are little and as they age through the teen years is really important, because 90% of peak bone mass is accrued by the early 20s, and then the remainder of that by about age 30 or so. So it's very important in terms of developing an ideal peak bone mass. It's kind of like, I think about it like retirement, right? What you have to spend in retirement is a function of how much money you've saved and put in the bank, similar to the peak bone mass that you've raised and then maintained, and then how rapidly you take that money out, or in the case of bone, how rapidly bone is lost through the menopausal transition and then afterwards. It's interesting to note that women can lose up to 20% of their bone mass during the first 5 to 7 years following menopause. Obviously, if they come in with a low peak bone mass, they are already at risk, and that's going to be realized at a much younger age. Next slide. Some interesting facts. The top half of the slide really speaks to the why we care and why we hope you care as well. And that's because osteoporosis is common. 1 in 2 women over the age of 50 and up to 1 in 4 men over the age of 50 will have an osteoporosis-related fracture in her or his remaining lifetime. If you think about the aging of the population and the silver tsunami, these are really huge numbers. But it's not just that somebody breaks something, it's the consequences of a break or a fracture. And we use those words in the medical realm interchangeably, but fractures can be life-altering events. We list hip fractures and some of the consequences up here because they tend to be the most devastating, but don't think that other fractures don't cause morbidity and mortality as well. Of the patients who have fractures, and there are roughly 300,000 hip fractures in the US every year, newer data shows that about 30% of them die within the first year following a hip fracture. Of those who remain alive, at least a quarter end up needing nursing home or other assisted living care. And most of the remainder never return to their prior level of functioning. That's not the way any of us or any of our relatives want to spend the remainder of their lives. So we should be aware, and that should be our call to action. And yet, although osteoporosis is treatable, if not preventable, most people who sustain a fracture are not tested, are not diagnosed, and are not treated. And this leads to secondary fractures that could have been prevented. So you see some of that data on the bottom hand left side of the slide in terms of 84% of people not being treated or tested in the 6 months following a fracture. And this results in what is a huge economic burden. So there's certainly a personal burden, but from a societal burden and an economic standpoint, from a study that we published a few years ago, cost of the 2 million fractures that occurred in the Medicare population in 2018 was about 52 billion. If we do nothing to stem this tide, that's projected to be greater than 95 billion by 2040. Next slide. The Milliman Group is an independent actuarial firm that did an economic analysis for us a number of years ago, looking at Medicare beneficiaries and the number of fractures that were sustained. So in 2016, 1.8 million Medicare beneficiaries suffered just over 2 million osteoporotic fractures. You can see the numbers in terms of mortality rates that I already alluded to earlier. Just shy of 20% of patients with any osteoporotic fracture died within 12 months following that fracture. You can see the numbers of people who became institutionalized within 3 years of the new fracture. And importantly, those patients who fracture have about 3 times the annual rate of new fractures within a year compared to the overall Medicare fee-for-service population. So fracture is the single most important risk factor for future fracture. Next slide. We recognize fractures, right? Spine fractures sometimes don't always present clinically initially, but most other fractures do. I mean, you see somebody on crutches with a cast, not able to walk. Shouldn't be hard to identify these patients. And yet they don't receive standard of care. And if we compare a fracture, sort of a bone attack, right, with the underlying disease of osteoporosis to an acute myocardial infarction or a heart attack, what is standard of care in that setting is not anywhere close or realized for fracture patients. We could argue that, acute MIs for the most part are a more male predominant disease, whereas bone attacks and fractures are a more female predominant disease. But in December of 2025, it would be malpractice if somebody got admitted to the hospital with a heart attack, didn't get evaluated, wasn't given a diagnosis, which we do regularly all the time, and then wasn't treated, right? Standard of care, beta blocker, baby aspirin, lipid lowering therapy, other interventions as well. And yet, if you think about the analogy with fractures and hip fractures per se, it is common that patients get admitted and within 6 months of the fracture, nobody gets a bone density test or other evaluation. They often leave without a diagnosis. Nobody links the underlying cause of osteoporosis. And only 21 to 23% of patients receive medication for the osteoporosis following a hip fracture within the first 6 to 12 months after that fracture. So we need to do something to sort of change what has unfortunately become standard of care. Next slide. We know what to do. We have a proven intervention to close the care gap. You'll hear these programs referred to as either fracture liaison services or sometimes post-fracture care, secondary fracture prevention. But these are well-established models that have been demonstrated to work both in the US as well as internationally and are supported by decades of evidence. And essentially, this is a multidisciplinary coordinated care system that is often championed by a bonehead such as myself and led by a coordinator who can wear many different hats. But it's a systematic way to make sure that patients who have a fracture are identified, then have a proper investigation, where appropriate, are treated and are followed so that they don't fall through the cracks. And what I just showed you on the last slide that doesn't occur doesn't continue to not occur. Next slide. So why aren't these FLS programs all over the place? And that really has to do what we'll talk about on the next slide with the fact that although we have data to show that these programs work and they have less than half the rates of subsequent fractures of systems where there are no such programs, patients have lower mortality rates, they get tested, we more than double the rate of treatment, and there's greater long-term adherence. And based on that same Milliman data I showed you before, if we reduce secondary fractures by just 20%, that could save Medicare fee-for-service $1.2 billion. That's just the tip of the iceberg. Next slide. But why don't we have these programs all over? It really has to do with the fact that we don't currently have a way to incentivize or reimburse people for the work that they need to do in order to run these programs. And with that, I will turn it over to my colleagues.
Thank you. So now I'm going to bring this issue closer to home and look at what's happening right here in Connecticut. More than 22,000 Connecticut Medicare beneficiaries experienced 26,700 fractures related to osteoporosis. So this is a population level problem, not an individual issue. And of those 26,700 fractures, they lead to enormous downstream costs in hospitalizations, rehab, long-term care, adding over $25,000 in additional medical spending for just 1 year after fracture. What's most urgent is that fractures are deadly. 20% of affected beneficiaries die within 1 year. And for hip fractures, it's 32%. So from a legislative view, this is a major driver of healthcare utilization, healthcare spending, and long-term care placement. Next slide. Fractures, this slide will talk a bit about the toll of fractures on Connecticut citizens and taxpayers. So fractures accelerate the opioid crisis. Nearly 1 in 4 hip fracture patients become chronic users of opioids post-surgery. And this adds layers of complexity to pain management, addiction risk, and the cost of treatment. What's even more concerning is only 7% of Connecticut beneficiaries receive a bone density test after fracture. And this is despite clear practice guidelines, as Dr. Singer just noted. And then beyond that, we see striking disparities. So Black and Hispanic beneficiaries are screened at much lower rates, 6.8% in Black patients, 3.3% in Hispanic beneficiaries. And so these gaps or inequities, they lead to preventable mortality, preventable disability, and preventable spending. Next slide. So we'll look at what citizens can do because the burden will only increase as our population ages. Connecticut is one of the oldest states demographically, so this is a growing wave. It's not a shrinking one. When we look at prevention and management, from that standpoint, there are foundational steps. So one is ensuring adequate calcium and vitamin D intake. Number 2 is engaging in weight-bearing physical activity. And the third is avoiding smoking and excessive alcohol intake, so making healthy lifestyle choices. But it's also essential to have conversations with healthcare providers, asking about fracture risk, asking about whether you should be screened. We often say that bone health is lifelong health. So the earlier that people are engaging, the stronger their outcomes. Again, as Dr. Singer noted earlier. But none of these are effective at scale unless the system supports access to care. Next slide. So we have also extremely effective medications categorized broadly as anti-resorptive or anabolic therapies. These medications either slow down bone breakdown or they actively build new bone. Osteoporosis is a chronic condition, so treatment isn't just one and done. It requires monitoring, adjustment, follow-up, and with the right therapy, we can dramatically reduce fracture risk. Yet, unfortunately, too few people are receiving these treatments. So this is an area where we have the evidence. Medical science is not the barrier in this case. The treatments are effective, they're available. The gap is really in access, diagnosis, and follow through, especially after a first fracture. Next slide. So we'll shift to some solutions that can create measurable statewide impact. Next slide. So one of the most impactful solutions is making fracture liaison services, or FLS, the standard of care after a fracture. These programs are proven globally to reduce fracture or refracture, hospitalization, mortality, and lower long-term care spending. But Medicare does not incentivize this care model, which is a major barrier to its widespread adoption. So if Connecticut leaders championed the need for Medicare payment mechanism for FLS, it could really transform outcomes here. And we've seen similar incentive structures that have been successfully implemented, for example, around opioid addiction treatment. So we could do the same for bone health. Next slide. We're looking at Medicaid data collection and analysis as another solution. So a critical first step for policy leadership is understanding the scope and the costs of fractures within Medicaid. Right now, many states don't have a clear picture of how much osteoporotic fractures cost them each year. So by collecting this detailed data on hospitalizations, long-term care, rehab, and even substance use, we can really identify where interventions would be most cost-effective. Next slide. And then Medicaid can play a pivotal role in shaping access to bone health screening and treatment. We know that quality measures like the percentage of women over 50 screened for osteoporosis create accountability, create visibility. There's also opportunity to integrate FLS type management into long-term support services and including also quality or performance measures on the percentage of patients experiencing osteoporotic fracture in long-term supports and services receiving FLS or being screened or treated for osteoporosis.
Just refer them.
So by integrating osteoporosis management into existing chronic disease programs, we leverage current infrastructure for significant cost savings. Next slide. Another major challenge is workforce readiness. So we have significant shortages of clinicians who are trained to manage osteoporosis and geriatric bone health, precisely the areas where need is rising. Supporting training programs, continuing medical education and competency development in bone health, women's health, geriatrics is essential. And this upstream solution, really, it pays for itself when we reduce fractures, hospitalizations, nursing home placements, and spending overall. And last slide. Finally, we cannot underestimate the power of education and public awareness. Public education is one of the lowest cost, highest impact interventions. So schools, senior centers, community organizations, and hospitals are ideal partners in developing or delivering basic bone health education. It should be a part of lifetime education, starting young, continuing through adulthood. And one of these areas that's so simple really is declaring May as Osteoporosis Awareness Month at the state level. This helps us to increase visibility and creates an annual opportunity for outreach. And I'll hand it over to Claire.
Thank you so much. We really very much appreciate, again, the opportunity to share this information with you, but we also welcome any questions you might have about what can be done in the state level, any additional data that you might need, or how we can be a resource to all of you as you try to address women's health in the state of Connecticut. And again, really very much appreciate you taking the time to hear more about how bone and, again, leading into it, menopause impacts the health of women. We also can talk maybe a little bit too about men's health. You know, we did focus here on women's health and making sure that we're addressing women's health needs because, again, the dramatic decrease in estrogen that brings on osteoporosis. However, it is a disease that impacts both men and women. And it's also a disease that often sometimes starts earlier in life. And so one of our trustees has shared, because of that peak bone mass that Dr. Singer covered, this really is a pediatric disease that manifests itself as we age. So it's really critical that we think about bone health across the entire lifespan when it comes to how do we keep our population healthy. So again, welcome your questions if there are any, or Claudio, if there's anything else you'd like us to cover.
That was a very thorough and well-described presentation of the issue, so I appreciate that. I'll pause and see if colleagues have any questions. If not, I think you've sent us, and I see some questions, but just for awareness, I know you've sent us the slide deck. Is that something that we can share more publicly if we talk to other interested parties or legislative leaders? Okay, great.
Absolutely. Absolutely. We'll make sure that you have access to this deck and this presentation. And we're happy to do follow-up presentations to anyone. If there's, you know, if you'd like to be done internally at your agencies, or if there's anyone else you think we should be speaking with, we welcome all of that.
Okay. I see Commissioner Giuttani from Department of Public Health. So go ahead, Commissioner.
Thanks very much, Claudio. And thank you all for that presentation. As an infectious disease doctor and somebody who certainly has a lot of family history of osteoporosis, and I've been interested in this topic for a long time, I did think I was coming in here and going to hear more about primary prevention. I really did not know our numbers on secondary prevention. I mean, this is quite unconscionable in my mind. I had no idea that the idea that people who have a fracture do not even get a bone density. I really thought what we were going to be talking about was primary prevention and, you know, initial screening with bone density. So I just wanted to thank you for that presentation and going over the data, because it really does help me from a public health standpoint, just understanding the spectrum of the problem we have in our state. You know, and certainly it's not within my purview, you know, looking at Medicaid, and I don't have that under me. But what I did want to say is that we do lots of messaging around prevention months. So making May Osteoporosis Awareness Month, I can commit to that right now. And I can certainly have messaging, you know, our social media, et cetera, go out in May around that. And to the degree, my ask would be if you have any prepackaged types of information that you can send to us. Miriam Miller is on, and you know, I have our Chief Marketing Officer, Maura Fitzgerald, whose team would coordinate that type of work in May. But if you have any materials that you can send to us around at least messaging and awareness, I'm happy to do that.
That's wonderful. And we do, and we will make sure that you get it.
Thank you.
I think we have another question. Go ahead. You can just unmute yourself.
Thank you. Great presentation. I think one of the things you mentioned early on is we need more data and we need more research on women's health. Are there specific recommendations, and maybe this even ties into some of the material that you presented was from 2016 data. are there things that you're recommending as part of health data collection statewide that we could encourage providers, either from a screening perspective or between employers and employees, that maybe would be helpful? And if there is any thought on that, you don't have to necessarily share that now, but if offline you could share that with us, that would be valuable.
Dr. Singer, you want to talk a little bit about the data, that collection? I think, again, we covered a little bit about, even just tracking within the state level. As the Millman report that we shared with you, that again was only on the Medicare fee-for-service, and we did not actually have Medicaid included in that. So Dr. Singer, sorry, go ahead.
Yeah, no, and there was a subsequent update to that, but it remains a challenge, obviously, on an ongoing basis to keep these numbers up to date. I will tell you that despite all of this attention, so Andrea, I think, put in the chat perhaps up there the cost of fractures, which was updated in 2021, not in its entirety, but some updated numbers. Obviously, that always lags a little bit behind in real time in terms of getting that information. We still haven't really moved the needle the way we would like to. I think one of the challenges and one of the reasons where in 2021, we did a state-based analysis, and that's where some of this information comes from. Some of our industry partners also have ways looking at systems and IDNs at a state level in terms of how they're doing, and it just helps us sort of drive this message. I will tell you, we haven't moved the needle the way we would like to, despite the fact that we know what we want to do, and much of that stems from lack of funding and lack of buy-in on the federal and larger level, but this is where on a state level, you can all sort of help drive it, and maybe then your claim to fame can be, you can have those numbers and the banners hanging where there is a difference. So I think from multiple pronged approach, we're trying to look at updating and continuing to update some of that information and try to drive those changes.
Professor McLeod, are there research-specific areas, particularly in your work, that would be helpful that could help lead?
I'm nothing beyond what Dr. Singer has mentioned.
Okay, terrific. Ms. Morton.
Thank you, and thank you so much for the excellent presentation. And actually, Andrea Singer really started to answer my question a bit, which was I was very interested in hearing about if you have in one place what states are doing to implement FLS programs. Who is there legislation behind that and the funding sources that they're using? No. Okay. So there's been no state behind.
Yeah, there is not standard legislation behind it. We are working at that and continue to work at that at the federal level. That's a whole sort of separate conversation. But, if there was buy-in, if there was incentive or funding or new ways to code, to be able to then put into place the people who need to be there for this relatively upfront labor-intensive approach to care, that would certainly make a difference. And that we do have a lot of information, though. Andrea can certainly send you links to, and along with the other packets of information that she'll send, some of the information that we do have and the kind of broader map and state level information. I think there was something else I was going to say in response to your question, but I
have a part two then, that if it's not happening on a state level in places where FLS programs have been successfully implemented, who are the key partners? Who's doing it, and what funding are they using?
Yeah, and that's a great question, because part of the problem is, particularly in the US, since we don't have Medicare in some respects is a national healthcare plan, but we don't have a national healthcare system. And so there is no one single database or way to capture all of these programs, to have data. I was just abroad doing some teaching and lecturing in Denmark and Sweden. They have a way to pull all of that data from one place and to know across the country and by counties and regions what's going on. We don't have that same kind of systematized approach. So we rely on, contacts and often bone health champions we know in different places, but that makes tracking data a little bit more challenging than in other places in the world. And I wish I could say I had an easy solution to that. That's one of the things we sort of are working on with some of our other society partners in terms of how do we get a better sense in terms of what exists, and then how to move this out and track it more broadly. Claire, do you have anything
That
you
is
want to
something
add
that
to
we,
that?
I was just going to say, there is something, that we would love to work on with states, and we're creating a model whereby states help set up the systems for how do we collect who is, doing a good job of referring patients, even for bone density tests, for post-fracture care, et cetera. I mean, there's definitely ways that we could work with on that. And I'd also like to just, interject again on from the National Menopause Foundation side, definitely working with you all to look at what are the menopause-specific legislations that are being considered, and how do we put screening and educational awareness for women at menopause get to that primary prevention, as was referenced earlier, right? We need to do both. There's such critical need for those of us at BHOF, again, thinking about that secondary fracture where there is that 80% care gap, where we know those patients are going to fracture in. So we're desperately trying to reach them and make sure that they get the care they need. But at the same time, we have to start working on prevention now too, right? And that's where we can go to that younger population and that menopausal population. Ms. Painter.
Hi, well, thank you for this wonderful information. I'm just thinking if you have stuff that we can work with individuals to self-advocate. So we get materials for statewide family council for individuals who are on long-term services and supports, as well as a statewide resident council, because I think educating them and having them kind of stay at the hospital or when they return to the nursing home, giving them the information so that they can promote their own wellness, health, and well-being would be great. So anything you can send us on that would be great. Or if you wanted to speak at either of those groups, we would certainly welcome that.
I muted myself because my dogs were barking. We welcome that too. We do have a ton of information, and I say this, repeatedly. We have all the information you could possibly need about bone, osteoporosis, bone health, and if we can't get it to the people who need it, then what good is it? So we absolutely welcome you taking our information, sharing that information, and we are happy to speak with any of the groups that would need, again, if that would be helpful. But yes, we will make sure that you have access to all of it. We've spent a lot of time digitizing all of our information so that it's easy to be downloaded and it can be reprinted, but we also have bulk copies of things if, again, it would be helpful to have it for distribution purposes. We're here to work with you and be a resource in any possible way we can, and we really appreciate your willingness to do that.
Sure, we can even sponsor maybe that month for resident councils to education, things like that. So we'll be in touch. Thank you.
I think that we're actually out of time, and I think that might be all the questions too, Claudia. So I'll turn it back over to you, and thank you again for this opportunity. We're so grateful.
It's great, and I just want to wrap up because one thing that I had not realized but was eye-opening to me was the intersection between osteoporosis and opioid addiction. I had not seen that linkage, and so one thing by way of maybe follow-up that you may want to look at is Connecticut has legislation. We were successful with our Attorney General in joining several other states to set aside funding for opioid settlement dollars for remediation and looking at pilot programs to help people with addiction. And DEMIS, our Department of Mental Health and Addiction Services, I had not thought to extend the invite to them today, and that was probably bad on my part, but it may be worthwhile to follow up with them. And I could put a link in our chat here to the website with the Opioid Settlement Advisory Council and see if there may be some cool intersection there where you could frame up a pilot for their consideration out of that funding opportunity.
That would be great. And, we find that at the federal level too. And this is something that everyone is always shocked to hear about. When we talk about who is your opioid addicted consumer, it's your grandmother and your grandfather. We have a different vision of it, but honestly, that's a huge portion of it. And again, it is for pain relief. And so we have tons of information to share on that.
Great. Well, I think we all benefited from having a step to, stepping into some of the data and the analysis that you all shared. Great conversation this morning. And we look forward to some of the follow-up materials that you'll be sending our way.
Thank you.
you,
Happy
Flynn.
holidays, everybody. Thank you so much.
Holidays.
Take care.
Thank you. Bye-bye.
Thank you.
Thank you.